Hey guys, it's Pete Croft, one of your ultrasound fellows. This week we're going to be talking about nerve blocks, in particular some of the higher yield blocks in the upper and lower extremities. These blocks will be important for you both here, particularly in fast track, as well as when you move on to the community. Um, I do quite a bit of moonlighting, and I can't tell you how much these have come in handy over the last few years. Um, they're particularly useful since they're easy to find, easy to access um, with ultrasound, and patients tend to love it, and they tend to make a clean procedure in terms of laceration repair, etc., and make it easy on you as well as the patient. This pictorial is important to commit to memory, as you'll notice the nerve distributions both on the palmar and dorsal surface of the hand. The ulnar as well as the median nerve distribution does kind of cross over the top of the fingertips. Um, so that's important to know when you have complex finger lacerations. In general, the ulnar and median nerve serve to um, innervate the entire palmar surface, whereas the radial will capture some of the dorsal surface, with the ulnar consisting of most of the dorsal surface of the hand. But definitely commit this one to memory, um, and look at it and study it and use it in your practice. First off, we're going to be doing the median nerve. This is probably the easiest one to find. You simply, as you can see here, you prop the patient's arm on a table or bed, palm up, and you put your probe right kind of in the meat of the forearm, right in the middle of the forearm. As you can see here, here's the corresponding image. You can actually see it on this screen as Scott points to it. It's pretty much unmistakable. It has that honeycomb appearance. It's hyperechoic, and uh, as opposed to the surrounding structures, as you move your probe up and down the arm, if you're confused, this nerve will stay steady and stay right in the middle of your screen and won't change its characteristics very much. So this is the first nerve I always show people since it is tends to be the easiest to find. Again, right in the meat of the forearm, right in the middle. Your depth for most people is only a centimeter or two, um, and nerves do tend to run with fascia, and that's what this is. It's just one of the fascial planes of the muscles of the forearm, one of the flexor muscles. So again, right in the meat of the forearm, there's your median nerve. You can follow it up and down to make sure that that is your nerve. This is your technique for blocking this. Again, I find a spot that's nice and close to the surface. Here you can see from looking at the left image, it's only about 1.5 centimeters or 2 centimeters down. Most of our needles will get that easily. And I'm holding the probe, and I usually attack this nerve or go at this nerve um, in plane, which means I'm watching the needle actually come in from the side of the screen and go right down to the nerve, bathing that nerve in fluid. You do not want to inject into the nerve. The patient will tell you if you're touching their nerve, they'll feel a sensation in their hand. You want to try to bathe the nerve all around to get a good block. Again, you don't need much in terms of lidocaine here. You only need a couple cc's. You don't need 10, 20 cc's for these blocks, which is another nice thing. And you tell patients it usually kicks in 10, 15 minutes and will, with lidocaine, last up to 1 to 2 hours. Important to tell patients that before you do the procedure. But again, you don't need much for these blocks, which makes them pretty easy to do. That's where your needle is going to be coming in from the left side of the screen there. And you'll be able to watch it the entire time. You don't have to look at your hand, you just watch the screen. In terms of the ulnar nerve, the way I usually teach this is I want to find the ulnar artery down near the wrist, and then you're simply going to follow that artery all the way up towards the elbow. Here it is here, ulnar artery, and as you follow it up towards the elbow, there's your artery, you're moving up, and there's your nerve splitting off. So the nerve tends to split off about 2/3 of the way up the forearm. It's a little bit tricky to find, but it's nicely seen here in this ultrasound image. Here's the artery coming down, and here's your nerve splitting off right there. So when you attack this nerve, it wouldn't be down here near the artery. You'd want to go further up on the forearm where you're further away from the vessel. Again, you don't need many cc's. If you have a hard time finding it, and this is how you're going to be doing that, again, watching your vessel, again, 2/3 up the arm. If you have a hard time finding it, here's another trick. You can go right where you're going to hit your funny bone, what's called your cubital tunnel. You put your probe basically right in that spot, and this is the image you'll generate from that spot. So probe right in the cubital tunnel, and the only thing sitting in that cubital tunnel is your nerve. You don't have any vessels to worry about. It's very close to the surface, about 1 centimeter down. The only caveat for this one is patient position, so it can be tricky to get the patient in that spot. But if you're creative, which I've done it a bunch of times, it's not hard to do. You just need a little cooperation from the patient. And as you can see, it's very easy. Usually with this one, I'll do an out of plane technique because you have bones on either side. So I'll come in from out of plane and anesthetize the nerve in that regard. Yeah, from this side, is from the hand side of the patient. I'll come in with my needle as I hold my probe. Again, there it is. There's me showing you how I would do the procedure, and there's your nerve right sitting in that cubital tunnel. Funny bone sensation, and that's how I'd come in, and you'd see your needle. You'd see just the tip, so you'd have to inject some fluid to see where you are as you come in. Nextly, radial nerve. Basically the same technique as the ulnar nerve. Both the radial nerve and the ulnar nerve are going to be on the outside of their respective arteries. So the ulnar nerve will be on the ulnar surface of the ulnar artery. The radial nerve will be on the radial surface or side of the radial artery. Again, here is coming. You start at the wrist. Here's your artery here. As you come down, your nerve will split off. This nerve can be tricky to find. On some patients, if you don't do this technique, if you start higher up on the forearm, if you start at the wrist, you move up, there's your nerve splitting off, again, following the fascial planes, which is characteristic of most nerves, following the fascial planes, splitting off, and again, you're going to eject it up further on the forearm, away from the vessel. There it is, splitting off. You can either inject, this would be out of plane. If you want to inject in plane, you can certainly do that. You'd come from the radial surface of the forearm away from the artery, and you can watch your needle go in and anesthetize that area. The spot I really like to go for the radial nerve actually is up where it wraps around the humerus, kind of what you guys probably remember as a spiral groove. Kids have fractures in this area and they get Volkmann's contractures. That's because the nerve sits so close to the bone itself. Here you can see it here. It almost looks like a spiral, or it's wrapping around the humerus. There's not much in terms of vessels here. As you can see, it's only about 1 centimeter or 2 down. It's very easy to approach. So I like to block this nerve in this area up here. The other bonus you get there is you do get some more coverage of the forearm because you get the nerve before it breaks off into its interosseous branches, which is a nice bonus if you have a complex laceration. But this is an easy one to access in this area, so it's another little trick. Ulnar nerve, you can get in the cubital tunnel. This nerve, you can get a little bit higher up here in the distal humerus, in the radial groove or the spiral groove. This is how I do this technique. I should tell you, it's kind of a neat thing to do that you can, a trick is to actually, if you bring the nerve to the side of the screen, so if, for instance, let's see if I can get this, if I bring this nerve over to the side of the screen, when you do come in with your needle, you barely have to go in at all. So when I do these injections, I try to bring the nerve on my machine, on my picture, over to the side, and then I enter the screen or enter the skin from that side, so you barely have to go in at all. You don't have to pierce much of the skin at all to get to the nerve. It's just a small trick to use. So this is a pretty long distance. If you brought that nerve over to the right more, you barely have to go in with your needle. Hope that makes sense. In terms of femoral nerve, we'll be doing some sessions with the attending soon to roll this out. For hip fractures, that's more of a compartment block. If you want to actually block the nerve itself, you got to be a little careful because you do have some vascular structures right there. In this regard, you're going to have your nerve, your artery, and your vein. This is your femoral bundle. Here's your fascia lata up here. Here's your fascia iliaca just on top of the nerve itself. Ideally, you want to pierce through both and dump your anesthetic solution in and around this femoral nerve, which is triangular. This is where you're holding your probe. You're right in the inguinal canal area between the pubic symphysis and the anterior superior iliac spine, which is over here. You're basically holding it diagonally right in between those two structures. This is where you do your injection, approaching laterally. Your needle is going to be coming in from the side, and we'll be injecting the nerve in that regard. Sciatic nerve blocks are probably my favorite to do. I've only probably done them the least amount, but they're pretty neat. You can find both your perineal nerve and your posterior tibial nerve come together and converge into the sciatic nerve and then lead it back up into the spine. Your posterior tibial here is down on your calf, your perineal is down on the lateral surface of your calf, and as you come up, as you see here, they're coming together. So your perineal is here, your tibial is here, and they come together to form the sciatic nerve. This is, interestingly, anterior, more superficial than your popliteal vessels, and when you're doing a DVT study, you often will see this nerve. This nerve is great for complex or blowout ankle fractures for reductions. The one caveat being that it does knock out sensation to that lower extremity, so it needs to be done in careful conjunction with orthopedics in terms of assessing the exam for compartment syndrome, which is certainly a factor for patients that have large lower extremity fractures and complex fractures of their shin and their ankles. So it is a pretty deep block. It's easy to do, and the anatomy is pretty cool too here with it coming together. I hope that makes sense. Here's your perineal, your tibial, and this is the location of the probe. This one's a great block for if you're going to be working at Cape Cod or somewhere near the coast where people are going to be stepping on glass or seashells. In the past, they've done just a anatomic approach in which they pierced the artery and went through the artery and hoped that the nerve was behind the artery, the posterior tibial artery, or your PT pulse. But in reality, about 40 to 50% of these nerves will not be just behind the artery; they'll actually be more lateral. So you'll be missing the block in those cases. This nerve, the posterior tibial nerve, will cover about 90-95% of the sole of your foot. So it will cover most complex lacerations of the foot, which, if you've ever tried to anesthetize, primarily is quite painful for the patient. So here's your nerve here, just behind the tibial, posterior tibial artery, and injecting this would be, as you can imagine, slightly difficult. The key is you want to find your bone, your medial malleolus. You put your probe right posterior to it, and then you're going to be looking and searching for a good spot to inject. I would go up and down. This nerve does tend to come out from behind the posterior tibial artery a little more proximal, and that's probably the best spot to block it. You can enter from the side, again, bringing that nerve to the side of the screen and making your procedure easier for yourself. That's probably the best way to do it. So just to recap, get your hands on the probe as much as you can. Don't be afraid of the machines. Don't be afraid to screw up. Master the techniques that we talked about, fanning and rocking. And when you are comfortable, you get the best images. So when you're comfortable in the room with the patient, with the machine set up, you get the best images. Once you start getting good at them, teach them. Once you teach them, you'll get much better at doing them. So thanks for all your help. If you guys have questions, concerns, feedback, etc., just give me an email, and I'll be happy to talk to you. All right, thanks so much.